Evening, everybody. We'll just give everybody a minute more to join, and then we'll get going with the presentation this evening. Okay. Right, I think everybody that's in the waiting room has come in. So welcome, everybody. Tonight's virtual forum presentation is on virtual wards, fittingly enough. So I won't steal Ian's thunder. So I'm going to introduce Ian to you. Ian Goodhart is a consultant intensivist and anaesthetist here at the Trust. And since November, has also been the clinical director for the virtual wards, or he's been clinical director for the virtual wards, which opened in November of 2022. So I'm going to pass you over to him without further ado. Ian.
That's great. Thank you, Ashley, for the introduction, and thank you all of you for joining on this evening. I know your time is precious, so thanks very much for giving it to me so I can talk to you about what we're doing with virtual wards and why they're really, really important. I fear I might say some things which are controversial. I might offend or irritate some people with what I say, and I apologise in advance for that. I think some of what I need to talk about is about how we change our practice, how we think about things differently. And I don't mean to cause offence, but I'm very keen to start discussion and debate about what are the best ways we can adjust what we're doing to be able to embrace opportunities and change. So Virtual Ward has got a little team leading it. There's myself. I joined it in July, and then Gemma joined in August, and we had Kirsty as our operational lead, who's going to be replaced by Andy Bailey, with the task of getting up and running as quickly as we could. We hoped to get started in October. As it was, we started with our first patients at the beginning of November. I'm going to outline what the virtual ward is, explain to you what the challenges and barriers have been to our development of the project. I'm going to explain to you how you refer to the virtual ward and manage your patients, what the progress has been in CUH, and what the future opportunities are. I'm hoping to make this a little bit interactive. So in theory, if you were to use your smartphone or camera, if you scan the QR code, that will then allow you to vote on the slide, and the slide should, if the technology works, update with your responses. And I think that the understanding of virtual wards in the Trust is not as good as it could be. So I'm expecting most responses to be around sort of the partially mark, if it works. I'm hoping it does. So if you would scan the QR code and then link through, with any luck, the slide will update. So what I want to know is whether or not you feel confident in your understanding of how the CUH virtual ward works and how to transfer your patients into the ward. But like all these things, when you actually try them live, they don't always work, do they? Which is disappointing. But there we go.
I just click no, Ian, if that's any help.
Yeah,
Give you a verbal result.
Thank you, thank you. Well, that justifies me continuing then, and I'll
So did I.
curse the technology later. Never mind. So my expectation is that most of you don't know about the virtual wards. You'll have heard a lot about virtual wards, or you'll hear a lot about virtual wards, about the importance of flow, the importance of moving patients into different areas, the importance of the impact it has on the system, the impact it has on our ability to work. But this is where I'm going to be a bit controversial and say that I think what we actually really need to focus on is our patients. Many of you are still at work, I see, and some of you have managed to escape home. But if on your way home you were stopped and you were detained by a cheery actor or police officer and you were prevented from going home, if you were required to stay in a prison cell for the night, you would have something to say about it. I've got two diagrams here. One of them is a Victorian prison, and the other is a ward layout from a modern new build hospital, which was planned for construction next year. The sizes of the spaces, even in your own dedicated room, aren't that different. I'm pretty sure you've guessed which is which. I'll add in the rest of the details so then you can know which is which. But being a patient isn't very enjoyable. The few times I've been an inpatient, it's been a miserable experience. And despite the best efforts that we make to look after our patients, despite heroic efforts by the nursing staff, healthcare assistants, domestics, all the staff on the wards looking after our patients, being a patient is not great. For many of our patients, they have no choice. They need to be with us. But there's a significant number of patients who don't need to be with us. They're with us for reasons of logistical complexity of getting investigations done. In some cases, they're with us because we are uncertain and we fear that risk of discharging a patient into the community. We fear the penalty of failed discharge and readmission, whether because personally we feel we failed the patient because we said they will be all right and they're not, or because as an organisation it's not great to have failed discharges. Different professionals in different industries, if you like, and different public sector workers have completely the opposite problem. They worry about wrongfully arresting, wrongfully imprisoning patients and people, and the penalties for them are very, very high. Now, I'm not saying that we are imprisoning patients, but I'm saying that for these patients who could be managed at home, for some of our cancer patients who fear the number of days they've got left, every day is precious, and keeping them in hospital when they don't need to be in hospital isn't always the right thing to do. So, having been a bit controversial and probably overstepped the mark on impartiality, I'll come back to the facts and figures and tell you about what we've been doing and where the virtual wards have come from. So virtual wards are not a new thing. In fact, many of you in the hospital have been doing fantastic virtual ward type activity for many, many years, whether it's with OPAT, whether it's facilitated early discharge, whether it's the work which goes through Clinic 5, whether it's the heart failure team. And that's been really, really effective. And as an organisation, we've got used to that, and that's sort of been built into what we do. COVID pandemic obviously put massive stresses and strains, and the idea of managing patients in the community, of risk stratifying and identifying the safer patients and keeping them on board in the community became better known throughout the population and the politicians. So last year, the government realised that there was actually scope to use this principle and the experience which people have gained during the COVID pandemic and roll it out into further specialties. Now, there are hospitals like ours, which have been doing a lot of virtual type activity for many years, but there are many hospitals that have never done it. And so introducing this as a formal concept for them, empowering them, giving them permission to explore this, or in fact, making them explore it, suddenly became quite a key thing for the government, for the health service, or NHS England, and the media. And so there's lots of noise was being generated last summer about it. And the hospitals around the country were putting together their teams. But virtual wards mean different things in different places. If you take the NHS England definition of virtual ward, it's a virtual ward allows a patient to get the care they need at home safely and conveniently, rather than being in hospital. In a virtual ward, support can include remote monitoring and may also involve face-to-face care from multidisciplinary teams. It's a very open-ended definition, which allows all sorts of different models to evolve. And when we then start comparing what we're doing, it becomes very complicated because there are so many different ways of doing it. But that doesn't stop the government from doing that. It doesn't stop NHS England from collecting data, and quite rightly so, they need to assess the response to their new initiative. So if you were to look at the last 2 weeks in December, then the data there was quite interesting because there was a sudden increase. But by that time, about 5,700 patients had received acute level care at home through the virtual wards in 2022. 49% of that care was associated with frailty, and 28% with respiratory infection, and 22% for other cohorts. Now, the reason for this is that the drive with virtual ward expansion was influenced heavily by NHS England, who wanted and mandated a focus on frailty, respiratory infections, and heart failure. Of the ICSs around the country, 36 of them are using enabled technology, and the remaining 6 are supposed to be adopting that in the next few months. But there's huge national variation. If we look at East of England figures with uptake of the virtual ward, it's rumbling along slowly, but in December, Trust was struggling with capacity, and there was a big push to try and increase the numbers. We look closer at what's happening in our region. You can see Hertfordshire, who are very famous for their heart failure service, have obviously filled their virtual ward. We're down there at the bottom. If I go to the next slide, it'll be bigger. And you can see that The expectation within our ICB is that we have about 2/3 of the capacity that the north of the region would have. But you can see from the proportion shaded in that column, we're not using our virtual ward capacity enough. And that's the reason that I'm so pleased to be able to talk to you this evening. So why are our numbers low, and what can we do about it? Our numbers are low for, I think, quite legitimate reasons. There are virtual wards around the country who are functioning on a daytime basis, where the patients are identified by ambulance services. They are held in the community because they've decided not to convey them because they don't feel they need admission, and they will not have seen a doctor. They may, in a normal way of things, not have been admitted from A&E had they been conveyed. Whereas here in Cambridge, we are being very strict in trying to make sure that we are only putting patients into the virtual ward who would otherwise have been admitted. We could have cooked our numbers and just filled it up with all sorts of patients from ED, but that wouldn't have made any beneficial effect for us as an organisation. And we need to get benefit from this. We need to be able to change things so we can get more elective surgery done, so we can decant ED, we can get the right patients into the right spaces. I think our numbers are also slightly lower than would be hoped because of the existing activity which still takes place. So the OPAT work, the heart failure work, and the work going through Clinic 5. This is all still ongoing. Other hospitals aren't doing any of that. So they're using their new virtual wards to mop up this new activity for them, but it would be existing activity. Now, there is some value in us supporting those existing services, and we're working with those teams to see how we can do it. Because the last thing we want to do is undermine what has been decades or years of good, effective practice and good, effective care. And the third thing is communication and clinical engagement. There's a huge number of different teams and you all work in different ways, and it's all quite complicated. And so we want to make sure that as a virtual ward team, we get out there, we come to your meetings, we talk to you, we explain how we can potentially help your patients. That's all very well, but you still need to know what it is. So here at CUH, it's a service that enables CUH hospital clinicians to deliver care and medical management to their patients while allowing the patient to leave the hospital and remain at home for the majority of their care. Notice the majority of their care. You're allowed to bring them back if you want to see them face to face. You're allowed to bring them back for blood tests, for investigations. That's okay. As long as they don't need to actually be in a hospital bed overnight, you're in a hospital bed for the majority of the time, that's okay. Why should you use it? It's good for patients. As I said, there are some patients who need to be in hospital. They need the oxygen, they need the IV fluids, they need the regular IV medications, they need the intensive support of the nursing care. There isn't a care package at home for them. They need to be under your watchful eyes so you can see how their condition is changing minute by minute, hour by hour. There's a real risk of deterioration suddenly or unexpectedly. It's good reasons why your patients need to be on your wards. But there are still patients who are either at the end of their journey, who are recovering, who would be best served in an area where they can mobilise themselves, where they can be with the families, people who care for them, be in a familiar, happy, relaxed environment. Patients at the beginning of their journey, where the diagnosis is uncertain, but they're not so unstable that we need to keep them in. It can reduce the length of stay. If your patient is transferred, would normally be in for 10 days, but you transfer them to the virtual ward at day 8, that will reduce your length of stay to 8 days. It reduces the readmissions. Because with those patients have been uncertain, readmission is inevitable. If you've got the patient and you transition them into the virtual ward, but then they come back into the physical hospital, that's not counted as readmission. It's all part of their ongoing stay in care. The virtual ward can help us to increase capacity, can help with patient flow, and it can also improve continuity of care. For many of our patients who are in hospital for a long time, they get quite used to the environment, they get quite comforted by the attention, by the reassurance of the doctors and nurses being there with them. And then they suddenly find themselves at home. And that sudden transition to the home environment can feel quite isolated, can feel quite scary for many of them. The virtual ward can help us to smooth that transition, because they will go home a little bit earlier, but when they go home, they know they've got that regular input from the medical team that are looking after them and from the nursing team from the virtual ward who can help support them with that discharge. You can use the virtual ward for admission avoidance. So instead of bringing the patient in and keeping them as an inpatient while you wait for blood tests and investigations, that patient can potentially go home. If the results of the investigations means that you need to bring the patient back in, that's okay. And most patients don't seem to mind that. They often seem to report back that actually they were grateful that they had that extra 2 or 3 days at home. You can facilitate early discharge with those patients towards the end of their recovery, and that can be improvement. We function mostly in a shared care model, much as we do with your patients in HDU and ITU. When the virtual ward was set up, we weren't allowed to employ a dedicated group of medical doctors to be part of the virtual team, because obviously that would have been hideously expensive. It also would have massively undermined the quality, the specialist care which you're giving to your patients. So what we aim to do for the majority of the patients is a virtual ward team will provide the infrastructure, the daily interactions with the patients, will work within parameters that you set. So you can have your specialist input for your patients, you have oversight of their care, you have the ultimate decision making, but we do most of the day-to-day work for you. The aim being that we don't massively increase the burden on you when you've already got a significant workload. In the future, in the near future that is, we will have some dedicated virtual ward patients. Part of the reason for that is when we look at the admission avoidance work, the acute medical teams were struggling to take on additional workload, and there were challenges with patient handover and transition of care. So we are in the process of recruiting a dedicated medical team. In the interim, we've got approval for locum consultant and registrar posts, which we're very keen to have volunteers for, but also there are discussions with the medical consultants that do the on-call about whether or not they're going to be able to support the virtual ward with the on-call time. The aim of the virtual ward is to assist people getting home before the clinically fit date. Okay, you don't have to wait till they're fit for discharge, it can be done before. We support them by arranging for the blood test and the investigations. The patients with the kidney function where you want to just be reassured that it's continuing to improve. The patients where you want to be reassured that liver function is settling, that the inflammatory markers are settling. If they're stable, let them go home, and we can organise those bloods investigations to be done. The virtual ward nurses can go up to the patient's home, or the patients can go to one of the local hubs to get the bloods done. Imaging can be done with the same priority as if the patient was an inpatient. We can organise MDT meetings. We can invite the patients to those MDT meetings. The nursing staff are able to look for your results, follow them up, and escalate them to you if they are outside of a range that you've dictated. We can organise welfare checks. The ambulance service will go around and check on a patient if they're not responding to the phone, or if our remote monitoring indicates that we need to visit them. We can use Attend Anywhere, and the patients are very keen on this software. They're very happy to have remote consultations. And we've got equipment to enable us to do remote monitoring of their vital signs. The equipment we use is the Massimo stuff, so we can use continuous temperature monitoring. So on the wards, your patients you're concerned about sepsis, they'll have their temperature checked 4 times, maybe 6 times at the most in a day. We've got stickers, put them onto the patient's body, you get 8 days worth of continuous temperature monitoring, allowing you to detect those temperature spikes which occur and are hidden because they don't fall when you're choosing to check the temperature, allowing you to see that subtle trend in change of temperature, or equally to see the resolution in response to treatment. We can do intermittent heart rate, respiratory rate, oxygen saturations, or you've got the option of continuous heart rate, oxygen saturation detection. So we've actually got technology to be able to keep a much closer eye on these patients than we're able to do on our traditional wards. How do you refer a patient to the virtual ward service? So there are different ways you can do it, but the most important and the best way to do it is to use an EPIC order. So if you go to EPIC, and I'll show you into the order tab, type in virtual wards, you'll very easily see the option to select. If you're not comfortable with that, or you want to discuss it with a team, you can use secure chat to message them, or you can ring extension 806 806. What happens once you've made the referral through EPIC? The virtual ward will review the referral. The virtual ward team will meet the patient. The parent team will be asked to clearly document what monitoring is expected and what criteria you want us to respond to, so that we know if you want us to escalate and contact you if the patient falls outside those parameters. Whether or not there are parameters which will allow the virtual ward team to discharge the patient on your behalf. You need to make sure the TTOs are ordered. When you do a TTO for the virtual ward patient, they need to be issued with 28 days of medication, not the standard 14. We've got dedicated support from pharmacy who will help with the TTOs to make sure that they're correct, to make sure the medications are compatible with the virtual ward admission, and that duration is appropriate. Investigations, blood test imaging needs to be requested, and that needs to be done as an outpatient order. The after-visit summary needs to be completed upon discharge from the physical ward. The reason for that is that if a patient's out in the community, they may well turn up at the GP surgery. We hope they don't, and we support them very carefully and we make sure they don't. But if they do, then those GPs need to know what's going on. They need to know what the plan is. The virtual ward care is then shared, hence the red and black colouring. Once the patient has completed their time in the virtual ward, once they've recovered to the point at which they're medically fit for discharge, then at the moment the parent team need to complete a second discharge summary at the end of the virtual ward stay and to confirm the follow-up arrangements. It seems a bit cumbersome to have these two discharge summaries, and it is a little bit frustrating, but EPIC requires that we do it that way, and it makes sure that accurate information is communicated to the GPs. So I mentioned the EPIC order. So I've done a number of screenshots here. I wasn't not always allowed to share the screenshots because apparently that's outside of our contract with EPIC. But I'm assured that for this forum, with it just being with a consultant group, I'm allowed to do this. So the EPIC order, click on orders and type in virtual ward, and it will pop up with the option for referral to the virtual ward team. That will then take you to the next page, which has got 4 simple questions for you. The one to select here is going to be virtual ward. Has consent for the referral been obtained? So that means consent from the patient and also from the consultant in charge of the care. Your contact number, and does the patient meet the inclusion criteria displayed on the left in blue? Now, those inclusion criteria look like a great big long list, but they're all fairly obvious. So the first one, and the thing which has made it harder for us to fill the ward out, is that we need to make sure that without the admission, the patient would need a physical bed. The referring order must be placed by the patient's parent team. So again, you guys are in control. Nobody's going to be stealing your patients from under your noses. The referring clinician from the patient's parent team is to discuss it with the team. So just let us know, but you're doing that by placing the order. Representative from the parent team needs to be available to support the virtual ward team with specialist care and confirmation hospital discharge. So this means that when out of hours, in the same way that responsibility for those patients is delegated to the on-call team, the same thing needs to happen with the virtual ward team. At the moment, we're only doing for patients over 18 years of age, that the patient's been provided with information, that they're expected to improve, or there's a reasonable chance that they're going to improve. So nobody that you've referred to RRT that morning and then sending to the virtual ward in the afternoon, please. The care requirements. Now, if a patient's already got a care package in place and that's maintained, then they can go back with that care package if that care package is adequate for their needs. One of the great things about virtual wards is that with the admission avoidance, you can prevent patients from losing their care package. There mustn't be significant safeguarding or self-neglect, mustn't be substance abuser to the point that it will affect compliance. It shouldn't be a complex discharge. And patients must be able to manage their own medications, or somebody else living with them or caring for them will be able to manage it for them. They must be able to put the monitoring on or remove it as required. They need to be able to arrange non-emergency travel, and the patient needs to agree to it. So it's all fairly sensible. Once you've done this, EPIC will automatically move your patient into the refer to a virtual ward. So in system lists, at the bottom of that, you'll see virtual ward. If you open that up, you can see 4 subfolders, and the patient will appear in the review for virtual ward admission. The virtual ward team will then see that patient, they will click on it, they will review the notes, and they will fill in a little form they need to fill in before going to go and see the patient to verify that the patient's got a phone, there's no safeguarding neglect, no complex needs, and are they eligible for the virtual ward. If they are, then the nursing staff will admit the patient to the virtual ward. The process of admitting and requesting the order for the virtual ward makes a change to your discharge summary to indicate that the patient's in the virtual ward, and that should happen automatically. If you want to see who's currently admitted on the virtual ward, again, it's on that list. I've deleted the patient names and MRNs, but these are genuine patients who are in the virtual ward. Patients in the virtual ward, you manage them in the same way that you do with all of your inpatients. Many of you got used to the COVID pandemic thing of minimising footfall in the ICU, and so I know that many of you are very confident with managing the patients remotely, and this needn't be any different really. But across the banner at the top, you'll see the addition of the word virtual, and that little tab helps you with managing the patients, with doing the virtual ward admission, virtual ward daily tasks, and then the discharge. You don't need to do much with this, and it doesn't need to necessarily inconvenience you as medical staff, but it helps massively with the nursing staff management of tasks. Importantly is the orders. So if you want to place an order, to make it easier for you to place an outpatient order, if you click on the virtual ward daily, there's a little tab which will take you to outpatient orders, and that makes it much easier to order investigations and changes to medication. Any changes to medication will be facilitated by pharmacy, and any new medications will be couriered out to the patient in the same day. In some cases, if it's easier for the patient to collect them, then again, the virtual ward team will facilitate that for you. When the patient reaches the end of their stay, the discharge summary does need to be repeated. Some of the information will be pulled through, but it's just a case of populating these. When the virtual ward has got its own dedicated group of doctors, they will, I hope, help you by doing some of that for you or doing it on your behalf, if that's acceptable to you. So the monitoring data and the equipment that we've got. The patients, as I said, can have a range of devices. At the moment, we're giving the devices dependent upon the clinical needs. So not everybody is being sent home with everything. Part of that is about keeping the costs down, but also it's about minimising the burden on the patients. Our 80-year-old patients don't necessarily want to be burdened with having extra devices to think about if those devices are not going to be useful or influence the expected decision-making process. The data comes through to a dashboard which is currently with Massimo, which can be accessed from any trust computer. We can provide you with access to that information if you want to see the live data. Otherwise, my nursing staff are transcribing that data manually into Epic. There was a plan, and there is still a plan for that migration of data to occur automatically. And discussions are taking place still about the timescale for that work. In addition, the virtual ward nursing team can undertake home visits. They can go home to check on remove lines. They can go home to check on dressings, back dressings, other things. They can do blood tests and other things within the patient's home. We can ask the patient to come into assessment unit, and the feedback so far is the patients are actually really happy to do that. They're trading off a couple of trips to hospital for 4 days in hospital, and most of them seem to be very happy with that. The virtual ward team will facilitate all of that for you. We've had a few challenges with implementing any new service in the trust. It's going to be difficult. There are going to be things to overcome. So many of the virtual wards around the country have evolved from community teams. They've been sort of bottom-up projects, if you like, where the GPs or district nurses have recognised this need to try and keep patients in their own home to avoid unnecessary admissions. We set off on this journey trying to engage with the community teams, asking CPFT what they could do. And they were really keen to help. They were really keen to be engaged. But it became very apparent very quickly that they simply weren't able to recruit to the posts, and the teams in the community weren't able to expand in order to be able to take on the additional workload. So we've had to approach the virtual ward of CUH and in this region from a very hospital-centric perspective. But that isn't the way things are always going to be. We are looking at ways in which we can move more and more of the workload out into the community with the support from the wider teams. We need to do some more work with IT integration. There's been an awful lot of work, important work with the Epic upgrades taking place, and so the additional work to migrate the data hasn't happened. We have had challenges to think about the processes, and we all know how Epic and the workflows and how it changes whether you're in an inpatient or outpatient environment, and so that sometimes constricts what we can do. We haven't currently got dedicated doctors, which is something which is really important to help with the existing teams with the workload, but also so that we can do more of the admission avoidance work with scooping up patients from ED. The nursing staffing model was aligned to ward metrics, which doesn't really lend itself that well to what the nurses are doing. And so we're working with the Institute of Manufacturing to measure what's happening, which will allow the team to be tinkered and adjusted to be able to be more efficient. The feedback from many of your juniors is that they are struggling. You know that they're struggling, and you're all working really hard to support them. I spent several hours talking to registrars and fellows who worry about the additional workload that they feel the virtual ward might place upon them. They worry about being unable to see the existing patients within the daytime activity and that being handed over to the night teams. And I think that some of their concerns are legitimate. I think there's stuff that we can do to support them. But most importantly, if the virtual ward team know what you want us to do, we can do most of the work for you, and then we can escalate to you when it's necessary. We should have had dedicated physio, OT and pharmacy support. Unfortunately, we've not been able to recruit to the physio and OT posts, but I'm pleased to say that last week we appointed a dedicated pharmacist to help with the virtual ward activity. Communicating with such a big organisation is challenging. The trainees and fellows, there are many existing services and we don't want to undermine what you're doing. Equally, we don't want to create duplicate pathways where one patient with one condition may potentially be treated or managed in two very different ways or through two different systems, because that can cause complications. So we really want to work with you and those of you who are doing existing work to see how we can streamline and align things. Also, we're being notified of potential patients quite late in the day. Unfortunately, the process of onboarding in TTOs takes time. So if you can identify patients early, that's really helpful. And this issue of being identified late in the day, I'll illustrate to you graphically in a moment. We're collecting lots of data about what we do to try and make sure we can tinker it. If we look at occupancy, this is the occupancy since November. You'll see that generally speaking, up until December, we're only managing about 13 or 14 patients. But then in December and late December, we all did really well to identify additional patients, which boosted our numbers massively. Our total maximum capacity at the moment is only 30 in the formal virtual ward. Obviously, you've still got OPAT, you've still got the heart failure service and Clinic 5. But as we approach the regular high numbers in the high 20s, we'll then be able to recruit more nursing staff and expand the service. Our target capacity for the virtual ward is supposed to be around 90 to 120 in April, and then looking at about 160 by September, October next year. So there's lots of work to be done there. We look at admission by age. This isn't a service which is just for young people. We've had about 5 patients over the age of 90, but you can see that the vast majority of our patients are 65 and older. The average length of stay within the virtual ward is about 4 to 7 days. The government target is that it shouldn't be more than 14 days. We're able to see where most of our patients come from. A lot of them are coming from the emergency department, although most of our focus has been to try and get the facilitated early discharge because of the challenges which acute medicine have in taking on additional workload. If we look at the geographical area that our patients are coming from, this is complicated because across the whole of the country, different hospitals are running their virtual wards in different ways, different ICSs are running them in different ways. But what we've all agreed is that the patients will be managed by the hospital from which they've been discharged or that they would have been admitted to, which means that we potentially cover a huge patch. We try to be realistic about what we can do because we need to make sure the patient can come back to us reasonably, or equally that our nursing staff can get out to that patient if need be. So the yellow numbers in the red boxes are the numbers of patients from that postcode area. You can see that most of the concentration is obviously within the nearby geographical area, but there's a fair spread into the outer regions. Referral by time makes a real difference. Now, I know that the ward rounds take place in the morning, there's lots of tasks which have to be done. I'm really keen that if you've got a patient who might potentially be suitable for the virtual ward, or you think that's an option, if they can be flagged up to us early, then we can get those discussions, we can get those processes started, we can get that patient out of the bed much, much earlier. Because at the moment, the majority of patients aren't leaving until after 6:30 in the evening, which makes it very, very difficult to be able to use that bed for an elective surgical patient or to get the flow going through the hospital when people are in to do the work and manage those patients. Admission by specialty, most of our patients are general medicine, but we are the only virtual ward in the country to be 24/7 and to be open to all potential specialties. And I think this is really, really important. I felt it's really, really restrictive to have such an exciting development and expansion of service and to limit it purely to care of the elderly, frailty and heart failure and respiratory infections. Because actually, huge numbers of patients elsewhere in the hospital can benefit. And if we can help particularly surgical pathways, if we can look at the elective surgical pathways and help with that turnover, then we can make a real difference to patients and to the organisation. Feedback from the patients, best night's sleep ever. They felt they had a clear plan in place. They felt really supported because they had that immediate contact. A couple of case studies for you, a whole range from young patients with acute infections. They were on IV antibiotics, transitioned to oral antibiotics and went home more rapidly than you would normally do because they could go home with blood pressure, heart rate, that kind of thing. The virtual ward team kept an eye on them. They progressed as the hope, and they were discharged from hospital, saving 3 days of hospital admission. 82-year-old waiting for aortic valve insertion. These guys have been kept on the wards waiting for the bed because it prioritises them in the Papworth waiting list. Around the region, and Norfolk and Norwich have been using virtual ward for their valve replacement patients for the last year, and they get managed in the same way as inpatients do. And so we've been doing that. Oncology patients really appreciate the opportunity to be able to get home. And for many of these patients, whether we're worried about sepsis, the continuous temperature monitoring has been really, really helpful. Video consultations have enabled that patient to remain at home away from hospital-acquired infections. How are we performing compared with other areas? So the government produces a report which looks at the cost per bed and number of beds. You can see that we're kind of in the middle of the pack, which is fine. I think that shows, especially when we consider the huge variability in what happens in the different virtual wards around the country. As I said, there are some which, by our definitions, they wouldn't be virtual ward patients because they wouldn't be admitted, but they're just being monitored because that area is managing in that way. So I think given our approach, I think our performance is quite reasonable. How can you help us to help your patients? I'm really keen that, well, we expand, and as I said, the discussions are very positive at the moment about getting medical consultant input. The idea being that there will be a dedicated go-to person for the virtual ward team, which also means that if you as a surgical group or another medical group want a second opinion, you want some help with a complication with one of those patients, then you've got somebody else to help you with that. But also it means the virtual ward team won't necessarily be coming to you and pestering you all the time. They've got their own doctors to go to cover the basics, and that those doctors can then escalate to you if need be. Identify your patients early in the day, please. It makes a real difference. We're very happy to have referrals and for that patient, us to then decline them, or to say, well, maybe not today, but maybe we can tomorrow once physio or OT have confirmed their own. We're not going to complain if you send us patients that we can't then take. We really want to try and find out who we can take. And if there's a reason we can't take that patient, find out whether or not that's a failure in our service and whether we need to adjust what we're doing to be able to embrace that patient. I want your junior doctors to understand how it works. I really want to be able to come along to our educational meetings, to meet them, to talk to them. So because they're doing a lot of the work, they're doing a lot of the paperwork. You look at pathway design for some of the more complicated pathways or some of the elective pathways, so we can look at how we can plan for patients to come to the virtual ward as part of their planned care. Patients having elective surgery, if they know at pre-assessment that what's going to be happening, it's an expectation that they're going to be discharged slightly earlier than they would have done traditionally, that's far more effective. You need to know which consultant's responsible for the patient. I know that's tricky because you hand over patients, but if the juniors can update that list, that makes a real difference. Us knowing who we can go to talk to about the patients, both potential admissions as well as existing admissions. Clear treatment goals. If we know what you want to achieve with your patient, then we can help do a lot of the surveillance work for you. And virtual ward needs to be seen as a default stepping stone. We need to be thinking whenever we see our patients in the hospital bed, can they be discharged? If they can't be discharged, why not? What's the reason that we're keeping this patient in the hospital bed for? And for many of our patients who have absolutely different reasons, and it's absolutely right that you should be able to use a clinical judgment and say, no, my patient's staying there. Okay? But if that reason is something which could be managed in the virtual ward, we really do need to be trying to do that. We need to try and find the opportunities to free these patients up from our ward, to enable them to be home where many of them would be happier being. To be at home, to be monitored, to be cared for, to be observed, to be able to have their investigations like they would have done if they were an inpatient. To smooth that transition from inpatient to discharge, to enable that patient to be supported as they undergo that journey, which for some can be quite intimidating, to help them to get free from the hospital, to help them to return to their normal lives. The stuff which is coming in the future, we're going to have a dedicated team. We're working with orthopaedic teams about the movement units and embedding the virtual ward into their care pathways. We want to look at HPB and renal as well with that. And transplant teams are also having conversations with us. We're bringing in new technology with augmented reality with the Microsoft devices, with ECG and community diabetes and blood sugar monitoring remotely as well. Increased community input as and when they're able to do that. We're looking at greater alignment across the East of England with a clinical advisory board, bringing in all of the different virtual wards in this area to try and make sure that we've got support that we can benefit and learn from each other. Looking at massive expansion of capacity over the next 12 months. We will have dedicated physio and OT support who will be able to help with the assessments on the wards to get your patients out earlier. And for those patients who need a little bit of extra physio and OT support, that can also be delivered either remotely or in the patient's home. We're looking to get a dedicated space for assessment, and so that when we are bringing patients back into the hospital, we can bring them back into a bed and bypass the ED way support and make it smoother, ensuring us that we can provide your patients with the quality of care and not give them any detriment by causing them inconvenience by having to go through the normal ED waiting bit. And we're also looking at options for bringing home oxygen in for short term for some patients who might need it just as a bridge to their full recovery. So that was a whistle-stop tour. Now, I was hoping this would work. It would be nice if it did. To do the survey bit at the end, but it looks like it won't be.
Ian, thank you very much.
Thank you.
Sorry to have missed the initial introduction for you, and very, very grateful for that comprehensive overview of the service. I think one of the key things for us also to remember is this is being recorded and then will be circulated to all our consultant teams with all the information and importantly the contact details and the processes of how to recruit patients into the service. So if anyone has any questions, I'd be grateful if you raise your hands. There's one that's come through the chat which I'll come to in a moment. So I guess we can start with a question from Uni Krishnan. You have, and Tony, if we can stop screen sharing perhaps, or we've got a result, so that's helpful. Uni, are you happy to state your question?
Thank you for the talk, and it's really helpful to know the details of this initiative. I've been scribbling some thoughts as I was listening to the slides. Is it possible for me to ask a couple of questions and raise a couple of concerns? It won't take long, I think, but I was just wondering if we could do that.
Yeah, go for it.
Yeah, please.
So one thing is there an option of telemetry for these patients? In terms of, so there are some companies that offer telemetry as in 24-hour tapes, but not in real time. Have you explored the option of having telemetry for these patients at all?
So we haven't gone down the route of telemetry at the moment because of our concerns that if we were doing that, we'd be doing it to look for sort of sudden arrhythmia. And at the moment, we felt those patients were potentially a little bit more unstable. But if you've got a patient group and you feel that the risk is reasonable and you feel that that would be of benefit, then absolutely, we would love to talk to you about that and see how we can incorporate it. But we were starting off with the sort of lower risk patients that were going to be, people felt more confident that they would be stable. But
the reason why,
yeah.
I mean, the reason to raise it is I was interested in the Norwich model of sending their aortic valve patients with severe stenosis home before TAVI. And in that context, we would have a concern about conduction system disease, and there may be an option to weigh up these things. I mean, obviously, we would make a decision on an individual patient basis, but it may open up a small subset of patients. I'm not saying this will make a big difference. So that's the reason to raise it, and I don't know of the technology. That is my first question. And the second thing was, I mean, given that this is virtual, do you think that there would be a potential for outsourcing of staff to manage and monitor these patients, in the sense that as you would have GPs working for Babylon or other firms, from other parts of the country advising patients in Cambridge, would there be an option of having outsourcing of medical staff or nursing staff to look after these patients virtually? So
the outsourcing is an option, and that's a solution which has been adopted by a number of other trusts who have wanted to rapidly produce a virtual ward capacity. That typically requires quite significant investment in money, and they have, because essentially what you're doing is you're paying for the staff, you're paying for another company to then profit from managing those staff. It's also often very narrow in the range of conditions that they're able to accept. I think it also undermines the value of your expertise and the expertise of the consultant group in the hospital. What we wanted to do was to make sure that all patients and all teams could potentially benefit from it. Whereas if we were going down the route of using the external providers, they were going to be far more narrow in the range of patients that they could take. It also required us to commit to a certain capacity which we would be paying for before we were necessarily using it. And then there were going to be conditions if we wanted to expand the pathways to take on other groups. But you're right, outsourcing is definitely an option. We've been approached by numerous companies who have been very keen for us to sign on the dotted line. The way we've evolved this is to try and keep it in-house in order to make sure that we don't lose staff to an external agency who would still want to recruit from a limited pool of nursing staff within the UK, and might therefore take them away from our organisation.
May I mention a couple of concerns?
Yes.
The first one leads on from what I asked, which is that cardiology at the moment, for instance, has a worst training record, with workload being the major reason for the poor GMC survey that we've had. And potentially we would have two parallel sets of patients, one in hospital and one outside hospital for the team to look after. So I do think that that is a concern we need to think carefully about. And I have my concerns about further workload to the junior staff and to the consultant staff for these set of patients.
The workload is something which is mentioned by a lot of people, and one argument you could say is, well, the workload is still there because you've got to define the number of patients who have a medical problem and need management for it, and they're either going to be managed in the virtual ward, or they're going to be managed in a bed, or they're going to be managed by sitting in a chair waiting for a bed. Obviously, I agree that assessment of the situation is excessively simplistic, and doesn't take into account the counter argument, which, like roads, the more roads you build, the more cars you get on them. So I totally get the concerns about workload, and that's one of the reasons that we're investing in having a dedicated medical team for the virtual ward to help support with that workload, to make sure that the only burden placed upon your team really is to give you expert direction, and that the day-to-day activities would be done by the virtual ward team in the most part.
Thank you, Ian. Only I'm just going to move it on there for a moment, if I may, because I know there are a few other people who've got questions, but I think the key thing from this interaction is that, you know, if cardiology have particular questions, get in touch with Ian and the team. Let's try and work it through. And I think it's fair to say every new service is going to require at some point a different or look at how we work day to day. And that clearly this will be no different. So perhaps a conversation for cardiology and Ian and his team would be helpful. But thank you. Ian, there's a couple of people asking about readmission and the need for that to happen, you know, in and out of hours. I think from what you said that the answer at present is that readmission, if somebody becomes acutely unwell or deteriorates, is still through the emergency department. Is that correct? So
what happens at the moment is the patients are readmitted. Now, the default option is that they come via the emergency department, as that is the standard gateway to our hospital. Also, our clinical area for the virtual ward consists of one room, clinical area, which is 2 meters by 2 meters, which is normally occupied by 3 nurses. We don't have a dedicated clinical area, and we don't have a dedicated room for all of those staff to be working in. That's something which we are working with the wide hospital team to try and resolve. So at the moment, the patients come through the safest option, which is come in through the ED, but our virtual ward nursing team go and meet them in the emergency department and fast track their transition through the emergency department to make sure, again, that we're not duplicating and overburdening the emergency department, but also trying to make sure we give the patients the best possible experience by smoothing their journey back to the parent team. In some instances, they're brought in, they're assessed, and then they're actually discharged back into the virtual ward. The virtual ward nursing team will facilitate that planned readmission of the deteriorating patient. And we've had to readmit, we expected we'd need to readmit about 20 to 25% of patients. We've been readmitting about 10 to 15%. And thus far, all those patients who have been readmitted have still been very happy with the virtual ward as a service and have felt that their deterioration has been well detected. There was one incident last week when the patient left the emergency department before having had their cannula taken out or been given their antibiotics because they got fed up of waiting in the emergency department. Unfortunately, that patient did deteriorate at home, but as a consequence, they didn't answer the phone. The virtual ward nursing team were unhappy that they hadn't answered the phone, and so the ambulance service went round to the patient's home to do a welfare visit, and the patient was brought back into hospital that way. Clearly, that was a problem because the patient had gone home without any antibiotics. They hadn't been treated for their infection, but that's a problem which occurred because of a variety of things. But the virtual ward was able to detect the patient and remedy the situation.
Thank you. And just on that antibiotic front, in terms of IV antibiotics, is there therefore a way of combining virtual ward care and OPAT care so that patients can still get IV antibiotics in the community, or is that a separate issue, or is that something you're still working on?
The OPAT team are very keen that, and quite rightly too, that they lead the service of delivering IV antibiotics in the community. They've got a good track record and an awful lot of experience, both in antimicrobial stewardship, but also management of these patients. However, to simplify what is a long discussion that we've had with them, the idea of the virtual ward is that we're taking patients who are not physically fit for discharge, and we're able to manage them. So those are patients who may be more complex or may still need specialist input from their parent team in addition to the antibiotics. So if you've got a patient who is on IV antibiotics, they still need to be given IV, but you think they could go home, then please refer them to us, and we will then liaise with the OPAT team in order to establish a shared model of care to make sure that that patient can go home if it's possible for them to go home.
Okay, that's really helpful for clarity on that. Thank you. And just as a sort of overview for again those not overly familiar, the type of conditions that you have been tending to, that the patients being treated in the virtual ward tend to be what, and what other types of treatments or conditions broadly do you think you could be helping with and treating, but you're not?
So I think the primary underlying diagnosis is almost unlimited, but in terms of what that diagnosis on the organ systems and the things that the problems that we are then treating. So these are patients who have respiratory infections is a common one. Quite a few patients with abdominal infections, so gallbladder infections, patients with urinary tract infections, patients who have got impairment of renal function as a consequence of recovery from sepsis or shock from other causes, patients who have come in with chest pain, which has been felt not to be cardiac in origin, or that they have been adequately stable. The frailty patients, a huge range of them. Patients who are at the end of their recovery, who we want to monitor them for recurrence of sepsis. We want to monitor them to make sure the renal function is improving. We want to monitor them in terms of, for some patients who have got sort of pancreatitic patients who are stable enough to go home, but again, we wanted to keep an eye on them, those sorts of things. It's so open-ended because we have so many different patients, but in some ways it's more limited by what we can monitor and what you're concerned about. So with patients with a heart failure, for example, they can be brought back into the virtual ward to attend the hospital, to Clinic 5 or one of the other areas. They can be given IV furosemide, they can be given and then they can be discharged on enhanced oral regime. They can have regular monitoring of the heart rate, respiratory rate and weights at home, and we can follow them up that way. The other end of the spectrum, the patients with the acute renal failure, they can come in, they can be given intravenous fluids as a bolus over a couple of hours to be rehydrated, and then they can go home with a plan to follow them up in 2 or 3 days. So,
thank you. That's very helpful, Ian. Thank you.
I'm sorry, it's a bit woolly.
No, not at all. But it just shows that there's a breadth to it that is important and for everyone to bear in mind that, you know, everybody is a potential candidate, as you've outlined. I think in the interest of time, what we'll probably do is wrap it up there. I know that there are some other questions coming in through the chat. So Joseph, Cherian and Uni has some further clarification he'd like. So I'm assuming, Ian, that if any specialties are particularly interested in engaging with you, or individuals with with questions, that they can be in touch to clarify some issues. Is that reasonable?
Absolutely, please do. Either as a formal way in a group or an organisation with your leads, that's fine. We can have formal chats about pathways. But if you've just got a patient, any patient that you think might benefit from this, just please get in touch with us and we will very happily talk through it.
Well, that's really helpful, and I think there may be a bit more of that once we circulate this for others to see who've not been able to join in real time. So once again, Ian, thank you for that really comprehensive overview. I think it's a really exciting and important service, and the whole idea of this was to really raise the game and raise everyone's awareness and allow us to maximise our safe implementation of that with our patients. So thanks, Ian, and thanks all the team that you're working with and everybody who's here tonight. Very much appreciated.
Thank you very much, and thank you everybody for joining, and really grateful for your time.
Thanks a lot.
Thank you.